Hello, everyone. Um, I'm Brad Rovin. I'm the Chief of Nephrology at Ohio State University in Columbus, Ohio, and I'm part of the Lupus Forum. My expertise is in lupus nephritis, and today we're going to talk about two of the papers we felt were relevant for the lupus community to think about, and they are both looking at different aspects of lupus nephritis. So the first paper is entitled BCMA-targeted CAR T-cell therapy can effectively induce disease remission in refractory lupus nephritis by Hu and his colleagues. And this came out in this year in Annals of Rheumatic Disease. And this is the study design, and we'll just sort of talk through this. As you all know, there's been a huge interest in cell therapies for autoimmune diseases. And this started off with some of the work from the German group led by Dr. Schett. And most of the work has been done so far using autologous CD19 CAR T cells. And these are cells taken from the patient and then manipulated to attack CD19 B cells. In this particular case, the investigators wanted to look at a BCMA-targeted CAR T-cell. And the difference is that BCMA is an antigen expressed on longer-lived plasma cells and antigen-presenting cells, whereas the CD19 CAR Ts target cells in the periphery and some antigen presenting cells, mainly plasmablasts and maybe some short-lived plasma cells. So, of course, the idea was, could the elimination of these antibody-producing cells reduce or help treat patients with refractory lupus nephritis? And so this was a single center investigator initiated trial. The patients underwent, these patients all had what appeared to be refractory lupus nephritis. They'd all been treated with many therapies prior to starting the CAR T cell and had not responded appropriately. And so they underwent leukapheresis, where their peripheral lymphocytes were removed, and then their BCMA CAR T cells were created. That takes a period of time. They're off immunosuppression and then prior to the harvest. And then the patients are lymphodepleted before they get the reinfusion of these BCMA CAR T cells. The lymphodepletion consisted of cyclophosphamide and fludarabine, eliminating all of the lymphocytes, and then the CAR T cells were given back to the patients. They followed the patients for a median of 9 months, but several were followed out to a year. And you can see what clinical assessments and the immunologic monitoring were done. But what was really interesting was a kidney biopsy was performed in one of the patients after 6 months after getting the CAR T cells. And I will talk about that a little bit because I find it quite interesting. So 7 patients were enrolled in the study. And the first thing that we note is that the peripheral B cells and the BCMA expressing cells from the periphery were very quickly eliminated from the circulation. Most of these patients had cellular recovery by about 3 months. The patients did become hypogammaglobulinemic, as expected if you're eliminating plasma cells and plasmablasts. The toxicity of the procedure was pretty well tolerated. There was only one low-grade cytokine release syndrome and no neurotoxicity within these patients. And actually, we've seen that a lot of the CAR T cells don't have the same level of toxicity as when this is done for cancer cell therapy. The SLEDAI-2K scores went from a very high level at baseline to 0, with a little bit of a range, of course, but a median of 0. And then 5 of the 7 patients achieved DORIS remission. Now, what was interesting was when you actually get into the data granularly, these results were a little bit different than what we saw with the CAR T cells that were CD19 directed. The patients did have, some of the patients did have a long-term drug-free remission, but at the end of 9 months to a year, the parameters suggestive of active lupus started to reappear. And so what we saw with Dr. Schett's patients was 2 years or more with drug-free remission. So it isn't clear to me after reading this paper that we can get sustained control of lupus nephritis after the CAR T cells or the BCMA CAR T cells. The other thing was that in contrast to some of the other publications on CAR T cells, proteinuria did not go to 0 in all of these patients, and many retained a significant degree of proteinuria. And this is to me not unexpected, because if you have refractory lupus nephritis, some degree of damage would probably have occurred in the kidney, and so getting down to no proteinuria might be impossible. But repeat biopsies were not done in the majority of the patients. In the one patient that did have a repeat biopsy, this was a patient who had class 3+5 lupus nephritis to start with. And the repeat biopsy showed a complete elimination of immunoglobulin by immunofluorescence in the kidney after 3 months or after 6 months of therapy. That's rather remarkable. When we look at, and we've done these studies ourselves and actually have discussed this in the Lupus Forum in the past, when we look at immunoglobulins remaining after therapy with conventional immunologic therapies for lupus nephritis, immunoglobulin fluorescence can last for months to years after patients achieve sustained clinical and histologic remission. So this has been shown with other CAR T cells as well and is consistent. I did look carefully at the biopsy material that was presented in the paper, and it's very difficult to make any particular judgments. This was a class 3 and a class 5 patient, but I really didn't see a lot of proliferation in the routine histology staining of these glomeruli. So perhaps the class 5 component was more prominent as being refractory in this particular patient. In any case, the conclusion of the study was that we could get control of the disease with a BCMA CAR T-cell without a CD19 component. It was tolerated very well by this small group of patients. The limitations of the study, of course, are that this was single center and of single arm and a very small N. Nonetheless, I think this opens up the possibility that in addition to CD19 CAR T cells, which are undergoing trial right now, as well as CD19 BCMA bispecific CAR T cells, seeding BCMA CAR T-cells may be another therapeutic option for our patients. Okay, let me move on to the second paper, and this is a paper I participated in. The title of the paper is "The Effect of Long-Term Voclosporin Treatment on Renal Histology in Patients with Active Lupus Nephritis with Repeat Biopsies." And you can see here the co-authors on this paper, and this was also published in Arthritis and Rheumatology this year. And so this was a trial of a sub-study of the Aurora trials looking at voclosporin added to standard of care therapy for patients with lupus nephritis. And as you all probably know, voclosporin in these phase 3 randomized controlled trials provided the proportion of patients who achieved complete renal response was greater. This led to approval for voclosporin added to a background of mycophenolate and prednisone or glucocorticoid, approval for the treatment of lupus nephritis. And so one of the things that we were very interested in as these trials were designed was how did the kidney respond to voclosporin? And one of the concerns was that, of course, voclosporin and other calcineurin inhibitors are T-cell drugs. We use them in kidney transplant, as is well known. And but they also can stabilize the podocyte, cytoskeleton, and they can decrease proteinuria through hemodynamic means. And so we were especially interested in looking at whether or not we did get good control of activity with the voclosporin-treated patients. The other thing that we did want to look at is calcineurin inhibitors are known to cause calcineurin nephrotoxicity, which is mostly a chronic damaging process to the kidney. It's not one histologic lesion, but it's a combination of histologic lesions in patients that are receiving calcineurin inhibitors, and we see this in the kidney transplant population. Voclosporin is sort of a novel calcineurin inhibitor, and we wanted to see if that carried the same degree of nephrotoxicity as the legacy calcineurin inhibitors such as cyclosporin and tacrolimus. So we asked patients who had a kidney biopsy prior to entering within 6 months of the Aurora 1 trial if they would like to undergo a second biopsy during the Aurora 2 trial. And we had several patients volunteer to do so. There were 16 patients in the voclosporin arm and 10 patients in the control arm that had kidney biopsies that were repeated. These patients were representative clinically of the entire larger study. And I realize this is only a small percentage of the patients, but still something relevant and has not been done before in lupus nephritis trials. And then these biopsies were read in a blinded fashion by nephropathologists and graded. And so to sum up, what we saw looking at chronic damage to the kidney was that the patients in the control arm and the patients in the voclosporin arm both had fairly common, very similar levels of chronic damage at entry to the study. And importantly, most of the voclosporin patients had no change in their chronicity index or a very small change in the chronicity index at the end of a median follow-up of about 18 months after being on voclosporin. And this was similar to the patients in the control group, where we would not expect, of course, to see any sort of chronic damage due to the calcineurin inhibitor. But of course, we know that even as patients are being treated for lupus nephritis actively, chronic damage can accumulate in the kidney. So that was reassuring. However, calcineurin nephrotoxicity can also affect the renal vasculature and the tubular interstitial compartment. And so we looked particularly at tubular changes as well as vascular changes, and we did not see any suggestive indication of calcineurin nephrotoxicity in this small but important group of patients. Activity index was a little bit more tricky. It turned out that a lot of the patients who entered the study with proteinuria that met the qualifying criteria actually had an activity index of 0. And there's several things to point out here. One is that when we looked at some of these patients, they were in the study with a component of class 5 lupus nephritis. And of course, class 5 lupus nephritis traditionally isn't graded with an activity index. So that accounted for some of these patients. Others did not have any activity and did not have class 5 lupus nephritis, but they had sufficient chronic damage to result in ongoing proteinuria. So that was a little bit misleading for the folks enrolling the patients into the trial. And then 4 of the patients remarkably had an activity index of 0 without much chronicity, and we did not we find that very difficult to explain, other than the kidney biopsy is a small fraction of what of the kidney, and sampling error or the discordance between histology and clinical manifestations might explain that. In any case, the patients who had activity indices that were 1 or more actually mainly had resolution on the second biopsy. But what I took away from this is it's very important for our clinical trials in lupus nephritis to have biopsies adjudicated. These biopsies were read locally, and the investigators felt that people had active lupus nephritis and needed treatment. And so I think what I take away from this is that going forward, we really do need to actually look at the biopsy reports and see the tissue, usually or preferably through a central reader, to adjudicate and make sure that the majority of patients do have active lupus coming into a trial. And this is not to say this is a small sample of this large Aurora trial, and it's not necessarily representative of the activity indices of the other patients, but you can see where this could cause some confusion with data interpretation. And so many of the trials we're doing now do have central reads of the kidney pathology. So I hope this has been informative. I suggest looking in detail at these 2 papers because they are providing interesting and new thoughts on lupus trials with lupus nephritis patients, the role of the kidney biopsy, and ways to think about treating patients with cell therapies. So I thank you for your attention.